Thank you. So one of the scary things about being on a panel like this and an audience like this is it's an opportunity to offend just about everybody in the room. So I'll try not to do that, but I think for all of us in the room who live and breathe the issue of health and health care, we know why this is so difficult and why it's so hard to come to consensus, even at a state level, let alone a national level, to do what we all in our hearts and minds and what, in fact, the data are showing is probably the right thing to do. I want to start by saying if you accept the premise or even are very intrigued with the notion that taking the employer out of the middle of this and taking business out of the middle of this discussion, imagine how I feel and think about how nonsensical it may be to continue to do this on a state-by-state basis. I mean, the proposals that we're evaluating and entertaining at the national level could end up creating another private sector-like system, but each state having their own. So then we would end up with 50 Medicaid programs, 50 CHIP programs for higher income kids from working families, 50 different exchanges and private insurance subsidies being managed by states, and then you lay over all of that a national Medicare program, and then you continue to lay over all of that and what would remain private employer-based insurance, and it really, to me, then creates something even worse than what we have. And in terms of service delivery and getting a grip on quality and access and cost, and so it'll be interesting to see what we continue to debate at the national level, but it's somewhat sacrilege for a state official to question state flexibility and state programs, but I think we're at a point at the national level where some of what we're thinking about just doesn't make any sense anymore. So I appreciate the opportunity to make some comments. Now, having said that, there are a lot of things that states can do and can do better. And most states have been working, what I call the pioneer states, Minnesota, Vermont, Massachusetts. Their health plan did not happen in the first 2 years of that administration. They've been working on this for 20 years. They've been in the trenches. If you look at some of the cost reduction data and the coverage data from states like those pioneer states, and they've been at this for a long time. And I would argue that no matter what happens at the national level, there will always be a role for states and certainly for communities, especially for high-need, vulnerable populations, because health care is delivered at the local level. You've heard people talk about high-performing systems. Well, we have one right here in the city and county of Denver, and the best care happens in neighborhood clinics and bubbles up to our city and county-based hospital and works throughout the population through public health, and you'll hear Patty talk about this, but there will always be a role for states, not just on the regulatory side, but on the quality assurance side and on the management side, assuring adequate networks. And some of the things that we've done here in Colorado very quickly that are traditional things for states to do to begin to get a grip on those three parts of the stool, the access, cost, quality. We have increased eligibility in public programs. All of the states that you see as these pioneer states that I talk about and some of the leading states, the first thing they do is get their public programs under control. They use that leverage, draw down the federal match, increase access for the lowest income, most vulnerable populations, and we have done that here in Colorado. You have to simultaneously, you heard a reference to Massachusetts, by any measure of access, Massachusetts reform plan has been wildly successful on the coverage and efforts in terms of who they're covering now and people having access to insurance. But the two places where they're struggling, you heard, not building a strong enough primary care provider network first, and not addressing costs and cost growth at the same time that they expanded coverage. So they will tell you that their financing model is not sustainable the way it is now, because they didn't tackle cost containment and quality at the same time, and they're working on that, and they're very smart people, and I think they'll be as successful as a state can be, but if you don't do all of these things at the same time, as a state, you will find yourself exactly where Massachusetts is. So, we're doing all of the things that you're supposed to do in terms of looking at utilization, looking at transitions of care where lots of the waste and the quality fall apart, where the waste exists and the quality falls apart when people move back and forth between systems, investing in health IT, looking at our benefits packages and defining those better in our public programs. And in terms of quality, working with the private sector. Government programs and public insurance programs can drive a lot of good market changes, but we don't serve most of the people. We have all the money, but not very many people. Most of the people in Colorado are still served in the private sector and paid for by their employers. So we intend to use our share of the market and our clout to drive those systemic changes, but quality has to happen across the whole spectrum. So public-private partnerships are very important to us. We have all of our clients, about 800,000 in various programs, are served in the private sector. We don't have Medicaid clinics where people go. We rely on our private partners to do that. So all of the efforts around building quality incentives, reducing cost, are happening simultaneously here in partnership with the medical community and other interested parties, less so the business community, which I'm sure we'll talk about later. There's a lot states can do. There's only so far we can go without national policies and national financing solutions.